Hi, everybody. It's my great pleasure to today discuss with Brian Edlow about the topic of covert consciousness. My name is Jan Classen. I'm an associate professor at Columbia University. I'm a neurointensivist and investigate disorders of consciousness.
Thank you, Jan. And hi, everybody. It's an honor to be here today with you. My name is Brian Edlow. I'm a member of the Neurocritical Care faculty at Mass General Hospital and associate professor of neurology at Harvard Medical School. So let's start by talking about coma. What is it and what do we mean when we use that term in the ICU? A comatose patient is somebody who will not open his or her eyes, will not wake up no matter how loud you yell their name, no matter how hard you pinch them. And if you open the eyes for them, they will not fixate or track. They show no signs of awareness of self or environment. A patient in the vegetative state is somebody who has opened his or her eyes and shows signs of wakefulness, but is still unaware of him or herself and the environment. And the minimally conscious state, defined by Joe Giacino and colleagues, is one in which subtle, minimal signs of consciousness have emerged. And often the first signs we see in the ICU are localization to a noxious stimulus. The examiner pinches the patient and the patient purposefully pushes the hand away, an appropriate environmental response to a noxious stimulus. Or tracking with the eyes. And there have been studies showing that using a mirror to assess for gaze tracking is the most effective way to see that sign of minimal consciousness. Now, it's important that we use these terms together in a way that we all understand, because when we start talking about covert consciousness, the presence of purposeful or volitional brain activity as detected by an advanced technique like functional MRI or EEG in a patient who appears behaviorally unresponsive at the bedside, this phenomenon, covert consciousness, also referred to as cognitive motor dissociation by Nico Schiff in 2015 at Cornell, is one in which we need to understand the behavioral correlates of these imaging or EEG findings. And specifically, it is patients who appear to be in a coma or appear to be in a vegetative or low-level minimally conscious state. These patients who are not responsive on the bedside exam, these are the patients whom we are looking at with these advanced technologies to see if they can show us signs of volitional brain activity with fMRI or EEG. And Jan, you have done groundbreaking work in this area with your team at Columbia. Your New England Journal paper in 2019 really shed new light on this field, not just with regard to the presence of covert consciousness in the ICU, but also with respect to its prognostic relevance. And there was a particularly compelling story that you told recently about one of the patients that you took care of. So I wanted to pass it back to you to share that story with us.
Thanks, Brian, for framing this really well. So this is, we shared this case actually together in a paper we recently published in Scientific American. And this was a patient that we saw, a young woman that we saw a couple of years ago here at Columbia, who was 30 years old, and she had a hemorrhage in her brain, a bleeding, a ruptured vessel in the front of her brain. And to clinical examination, she was unresponsive. She was just lying there. She looked like she was sleeping. She couldn't be woken up with vigorous stimulation, just as Brian was explaining. And I remember very distinctly standing there with her parents and discussing what the underlying problem was and why she was in this state. And her parents asking, is our daughter awake? Can she hear us? And so we talked to them about a study that we were doing at the time where we put EEG leads on and we presented her and other patients with commands. We asked her, open and close your right hand, and then recorded the EEG while these commands were played, and then asked her, stop opening and closing your right hand. Mind you, the patient, of course, didn't open and close her hands, but we recorded the EEG, the response to this command. And lo and behold, when we analyzed the EEG, we found that she could reliably activate her brain differently to the command, keep opening and closing your right hand, compared to stop opening and closing your right hand. So she was able to distinguish these commands reliably. And this is the state that Brian was explaining can be detected with EEG but also with functional MRI. The original case where this was shown was published by Adrian Owen in a paper many years ago in 2006 in Science. And Brian, can you tell us a bit about that case that was there published?
Sure. And it's always inspiring to hear you tell the story of the young patient that you took care of, and especially because my understanding is she had an excellent recovery, and it speaks to the prognostic relevance of the task-based EEG that you were performing. With respect to fMRI, the classic Adrian Owen paper from 2006 in Science, a young woman who was several months out from a severe traumatic brain injury who appeared to be in a vegetative state based on her bedside behavioral exam. Yet when she was asked to imagine that she was walking through the rooms of her house, she showed activation within parts of the brain that are known to control that type of spatial navigation imagery. And when she was asked to imagine it that she was playing tennis, she activated the parts of her brain that are known to be associated with that type of motor imagery. And she could reliably activate her brain to these two different commands and show two different brain activation patterns. These fMRI data were believed to be the first evidence of covert consciousness, purposeful volitional brain activity in the absence of any purposeful behavioral findings on exam. And it has opened up an entirely new line of inquiry. Since that 2006 study, multiple investigations using EEG and fMRI have been used to probe for covert consciousness in patients who appear unresponsive. And it is remarkable the consistency with which the 15 to 20% number keeps showing up. And Jan, if I recall correctly, that was the percentage in your paper as well, 15%, is that right?
Yeah, it was interesting because it was on average exactly that, as you were saying, and we didn't expect that because that had previously been sort of reported in a larger study in the chronic, subacute chronic state. So we didn't necessarily expect to find such a similar rate in the acute state, but we did. And this followed up your important paper published in Brain, where you showed that you could actually detect these states of covert consciousness, not only weeks, months later, but already in the critical care setting. And that was an enormously important contribution because in that state, when it's shortly after brain injury, we can, first of all, there's so much treatment we have available at our disposal. And we can also talk about goals of care with the families. So this has potential huge implications in the acute management of the patients. And as you were saying, this patient that we followed there that we detected with covert consciousness, she actually had a full recovery. And a year after the injury, she was working again as a pharmacist. And this was not replicated only in this one patient, but we saw that patients that had covert consciousness diagnosed within a week of the injury had a much higher chance of being functionally recovered a year after the injury than patients that did not have this covert consciousness. And not only that, you could also see that the recovery occurred earlier in the patients that recovered with covert consciousness compared to the patients that recovered without covert consciousness. So this may be prognostically for the ultimate outcome and also for the intermediate outcome, an important state to detect. Brian, do you think you want to talk about a little bit about the potential mechanisms? We don't really know what the mechanism underlying covert consciousness is, but you want to talk a bit about what the concepts in the literature are right now?
So I think the most important thing to acknowledge, like you suggested, Jan, is that we really fundamentally don't understand the mechanisms by which a patient can appear unresponsive on the bedside exam, but show command following on one of these advanced techniques. There are a couple of small studies that have been published that provide some initial suggestions of what the underlying mechanisms might be. A paper by Davini and Fernandez-Espejo, which looked at structural connectivity in the brain of a patient with covert consciousness and found that there was disruption of the connections between the thalamus and the part of the brain that controls movement, the actual motor action, but preservation of connectivity between the thalamus and the supplementary motor area, which controls motor planning. So just an N of 1 analysis, and we have to take those findings with a grain of salt, but some pretty compelling and elegant evidence suggesting that there are specific disconnections that may lead to this syndrome. If I may just comment for a moment on the points that you were making earlier about the impact, the relevance of this phenomenon of covert consciousness being detected in the ICU. When we think about all the patients, there are many clinicians, I'm sure, on this Zoom right now who have taken care of patients who appear comatose, vegetative, or a low-level minimally conscious state in the ICU. And with further studies, if the data that you found bear out and are replicated, the 15% number in the acute setting, to think of the many patients we've all taken care of whom we thought were unconscious, but 15 to 20% of them may have actually been covertly conscious. I mean, at the very least, it reinforces the importance of speaking to patients in a compassionate, supportive manner, even when they appear that they don't hear you. I think that's the very least that we can do, just from the standpoint of a humane and compassionate approach to patient care. But you alluded to talking with families, the profound impact that this diagnosis, detecting covert consciousness, can have on a family's understanding of their loved one's current state of consciousness and chances of recovery. It's hard to understate. It's hard to overstate the importance of that. And I'm curious if it's changed the way, Jan, that you approach family meetings and goals of care conversations, even for patients where you haven't done task-based EEG. Do you approach those conversations differently now based on your findings?
I do. I already did this before we detected covert consciousness, because over the years, I've sort of, for myself, found that our ability to predict who's going to recover and to what state they're going to recover is just not good. We're not good at predicting recovery precisely. And this is true even with imaging techniques, structural imaging that we have widely available now, and other tests. So I've been cautious giving predictions like this patient has a X% chance of recovery. I don't think that actually we can do that. So I've become even more cautious, if anything, after now we found that so many patients have covert consciousness. I do instruct everybody, just as you're saying, Brian, when they're in the room, also outside of the room, when they talk about the patient or to the patient, to assume that they're conscious, that they can hear you. You don't lose anything by just assuming that they're conscious and can hear you. So I think that is very, very important. In the future, we could also think that detecting covert consciousness could become potentially a biomarker in treatment trials, even for sort of enrichment of the population when you start clinical trials for patients to support recovery of consciousness. But at a minimum, as you're saying, when we talk to patients and when we talk about prognostication, it will become an important tool, I see, in the near future.
As we look to the future, it's also important to highlight the last few years, there has been a rapid expansion of this field, especially with the leadership of the Neurocritical Care Society and the Curing Coma campaign, the extent to which more and more studies are being launched at centers around the world to detect signs of covert consciousness, and the degree to which clinical guidelines have also begun to embrace and endorse these techniques. So the 2018 US guideline and the 2020 European guideline, we are in this really exciting and interesting period now where diagnostic and prognostic tests that were previously thought to be solely within the investigational domain are now starting to cross that threshold into clinical care and clinical implementation. So lots to look forward to in our field. And I realize that we're almost out of time. I'm keeping an eye on the clock here. Any concluding thoughts, Jan, as far as where we are now and where you think we're going to be going as a field in the next few years?
No, I think what you mentioned, the Curing Coma campaign, is hugely important because it is a worldwide problem. Coma and states of coma and our inability to predict the future for these patients. So I think one of the most exciting things for me personally is this initiative that now spans includes investigators from all over the world. And one important part is that everybody can play a role in that. And it's not just physicians, it's nurses, it's nurse practitioners, it's physical therapists. We need a multidisciplinary approach and to look at a worldwide problem to make progress there and hopefully help these patients in a more adequate way.
Well said. And I would just add to that as a concluding thought that we have learned so much in the last 17 years since the first description of covert consciousness. And there is still so much more we need to learn about how the brain recovers consciousness after a severe injury, how people can reach their best possible functional outcomes. And with those major gaps in knowledge that we all need to work toward filling comes a need for us to continue to be humble. That prognostic humility that you discussed when you sit down with families, I just want to end on that note, the importance of us acknowledging the limitations of our knowledge, both when we communicate with each other at conferences and events like this, but also when we speak with families. acknowledging that there's uncertainty, and giving families the best information that we possibly can, but without being overly confident in those prognostications, given how many unanswered questions there are in our field. So with that, thank you everybody for your attention, and appreciate the opportunity.
Thanks, Brian. Thanks, everybody.
Thanks, Adam.